Respected seniors, colleagues, and dear delegates, a very warm good afternoon. I'm Dr. Praveen, and I'm extremely happy to be a part of this event organized by the Indian Orthodontic Society along with Manipal College of Dental Pricing and the Orthodontic Study. Well, it is actually a session which tends to train and finally get the final years crack the practical exam in the best possible way. Well, my sincere thanks to all of you all, and thanks to you, Siddharth, Ashay, Supriya, for considering me to take this session. Well, orthodontic science, an orthodontic diagnosis per se, cannot be an exact science. It is art, and mastering the art of observation needs experience and acquiring individual knowledge. It is a bit difficult to actually teach uh, like statistics or the measurement, which these days, this was said in 1949 and it said it still holds well. That is, a clinical observation is actually, you need to look for it. And I try to share my experience, which I gathered over my 30 years in orthodontics to track this clinical examination as much possible. Let me start by saying that, see, the first exposure to the external examiner happens with a myofunctional case analysis. So the examiner may not per se hold them to myofunctionals. We might go and ask how you had been doing case analysis for the past 3 years and how well you will be acquiring your information from those diagnostic records. So may not be with functionals, but here I have made an attempt to take an overall overview with more towards functionals. So the topic is class 2, where you give a class 2 growth modification. Like how do you diagnose, how do you select a case, and how do you do a bite registration? It's for the ease of simplicity or for better understanding, I've divided into clinical case taking. We speak about a bit of evidence and functional appliances. Ideal cases for functional appliances. We do a bit of effort to understanding the basis of what is a condyle, what kind of cartilage is condyle. We have a small discussion on appliance selection, and we end up by doing a by registration, and which will be question and answers. Let's see how it goes. Well, first, it's just history taking. Well, most of the orthodontic textbooks tell us that with a strict interview, history taking, the level of assessment of motivation and psycho, the first interview start. Well, it is taking as much good knowledge about the person, and it starts with collecting the vital statistics, the name, age, sex, the economy, the geography from which they're coming. Well, there are excellent articles which speak about what is in a patient's name, which is an article which came up in 2004 written by Recuse. We have a tendency to call by class 2 malapolations or deep bites. No, use names and talk to them so that they can relate to us because it goes from nearly to 1.5 to 3 years. So what is in a patient's name? So gender specificity, definitively males, females, they have their own outlook towards orthodontic treatment, their own aesthetic senses, so that which is different and which an orthodontist has to be familiar with. And well, health economy, well, what kind of appliances would you be suggesting, depending on the economical status of a person? So, well, these are important reads for by collecting vital statistics. Well, with regard to prenatal history, well, most of the myofunctional appliance patients, when in the age of 11 or 12, if they are pretty normal for that age, well, a prenatal history may not be of relevance, but that is not the case when you look at a syndrome or a cleft ear prenatal history needs to be very well collected. But a few things which was found very interesting was in postnatal history, the history of breastfeeding could be of a lot of relevance for a person with a class 2 because the first myofunctional appliance as suggested by Rakosi is actually human breast. Well, the mandible has to be brought in front. A small nibbling action of the lower lip is makes the milk get out. So the first myofunctional appliance is the breast. Well, there is this study which was quite interesting. In 2006, they said that there is a relationship between non-nutritive sucking. I suppose there is a discussion about sucking and suckling. Sucking is actually an active process that the baby has to take milk out of the bottle, and suckling is a very passive process. And in Thomas Recosi, there is a good discussion about temporalis cures and mesepic cures, the importance of shifting diet in early days. So, if you don't shift to solid food after a year, then you remain as temporalis cures who are weak chewers, and it is better you shift to become a. So, these are the relevant things when it comes to myofunctional. What is a temporalis cure? What is a mesepic cure? And which is the first biofunctional appliance. The medical history, well, these are the major medical illnesses which is applicable to orthodontics or orthodontic therapy or any form of other therapies. We need to be looking into this, but particularly with myofunctionals, you need to be careful with nasal stenosis, neuromuscular disorders, right? Cerebral palsy, or any muscle neuromuscular incoordination. The chances of success with functional appliance would be minimal because the appliance itself needs a coordination between the muscles and nerves. So, which would be an absolute contraindication for myofunctional autism, poor patient compliance, and poor oral hygiene. So that is with regard to the relevant history. We'll start with the first assessment, which I would call as growth assessment. So growth needs to be assessed, and how well and why do we have to assess growth? Now, this article, now what does it tell you is that once a class 2 is always a class 2. Class 2 is not a self-correcting malocclusion. There is an occlusal lock, and this occlusal lock is here to stay. You need to do something for the lock to break. Well, this is exactly what Franchi, Bassity, and McNamara said in 2008. That and more. This article said that, see, class 2 gets worse with growth. That is, if it is prepubertal, you find that class 2, it tends to worsen with growth. So that calls for correction of class 2. Definitely, you need to correct class 2. Now, this article, Timing of Treatment in Twin Lock, and by Francie Bassity, is actually telling us that if twin lock is given during the right time, you get greater contribution for molar correction, larger increment of total mandibular length, and more posterior jaw direction, which is exactly the changes a class 2 patient needs. But if at all it is done after growth completion, this is more towards genitoalveolar and skeletal corrections would be very less. Exactly the same thing is said in retrospective cephalometric analysis, which came up in 2023 from Turkey, which again says that Winlock, when rightly given, causes bone remodeling and reshaping in both jaws, but if it is done late, will be purely genitoalveolar. So that demands a good growth assessment, and we need to give the Winlock appliance when the mandible is growing to its full potential to get skeletal changes. So how do we do that? Well, you can use chronological age, biological age, like morphological age. Morphological age, I meant by you ask the height, the weight, or the secondary sexual characteristics. Well, you can use skeletal age, like Campus radiographs, middle phalanx, cervical vertebrae, frontal sinus, dental ages, like eruption status, mandibular canines, or molars. Well, there are a lot of articles which relate them. But see, these are all growth indicators which tell you that the person is growing. But what we are more interested is the mandible growing in the same way, or when is the mandible growing at its peak? So let's have a detailed discussion and correlating this with the mandibular growth. Well, as we spoke in general, Prophet says that there is nearly, this is taken from Prophet, it says that nearly girls have nearly 3.5 years of growth spurt, which happens with the development of sexual development. Well, the first periods of men are periods when the usually girls are in stage 3 or growth is nearly completed. After that, that's exactly what the prophet says. Well, voice changes, the increase in height are good indicators of this one. Facial hairs, it pairs upper on the upper lip. Well, they are on somewhere in stage 2 to stage 3. And if hairs appear in the chin, they are close to growth completion. So this can be taken up as a tentative parameter, that hair appearing on the chin and hair appearing on the upper lip equally. In boys, we have a growth nearly 4 to 5 years of growth, and it's a bit extended. Well, all these are actually related to mandibular growth. What we are more interested in is how is the mandible growing like the same way as the skeletal is growing. There's an excellent article which came up in 1972, which relates and which says that in girls, the mandibular growth actually succeeds the spot in height. That is, height happens first, and then the mandible grows. So, and in boys, they happen together. Mostly the height growth as well as the mandibular growth happens together. Well, again, it is found that all the dimensions are taken together. The correlation factors, if you look at that, with body height, dimensions, body, the mandibular length exhibit the consistent relationship with growth and height. So height growth can be considered as a good indicator for mandible. Menarche, skeletal age, peak of growth in stature are better predictors of growth for than chronological age. Sometimes we might tend to use chronological age by saying 10 years. Well, that can be used, but menarche, skeletal age are better predictors of growth. Now, equally, there is the Shuttleworth study which tells you about menarche being related to it. So this says that menarche happens, menarche has happened when the mandibular peak is over. So the menarche happens right after mandibular peak for most of the girls, unless they are late maturing ones. If you can conclude that, well, height, weight, menarche, secondary hair changes can be taken as good indicators, and mandibular growth can be related. Well, skeletal maturity indicators, a study by Hag and Tarranger, will suggest that initiation is very difficult to find out, but the peak and the end stages can be assessed well with clinical parameters and the radiograph and the voice in the sense. And well, let's have a discussion on hand-wrist radiographs being used as a tool for assessment. It is one of the gold standards. It's a wonderful tool. It is wonderful because it doesn't take just one parameter. We have a lot of bones, and all this is taken together to finally conclude that the person is in growth spurt. And this is a tool that is exactly employed by most endocrinologists and medicine people to assess growth. Now, mostly the left side is preferred for a light-handed person. It is purely because there is an asymmetrical growth which happens between the left and right side. The left side seems to mature earlier. Now, what exactly do you look in a hand-wrist radiograph? If there is ulnar sesamoid, there is hamate, the peak adolescent growth spurt is past. Even look at the middle line, the relationship between the epiphysis and diaphysis, if it is epiphysis is smaller, if it is the same site, it is scab. Well, a lot of things can be used in a hand-wrist radiograph. And skeletal maturity assessment with hand-wrist radiograph is considered to be a gold standard for skeletal assessment. Well, this was an idea that Lemparski put forward in 1965. He said that, yeah, cephalogram gives us information about growth, and he was looking at the cervical vertebrae. Well, in 1992, it was Hazel and Farman who made it into an index, and in 2000, Francie Bassett again divided into CS1, CS2, CS3, and cervical vertebrae started being employed as a growth or a maturity indicator. Well, yes, cervical vertebrae do show changes from, they have the stages from CS1 to CS2. Well, CS1 and CS2 definitively there are three pivotal, a lot of growth is left. CS3 peaks the peak mandibular growth, and CS4 the mandibular growth is achieved. It's nearly over. That's exactly so. We have learned that CS1 and CS2 for maxilla, CS3 for mandible or myofunctionals, as exactly as a plan suggests. Well, now here, this is taken from Pabon, and it says that the onset of adolescent growth spurt in height, facial size, and mandibular length started in females at the age of 9 and it peaked at the age of from 10 to 11 years. So 9 to 11 years, and at 11 years there was a peak. For males, it started at 11 years and it peaked at 14 years. For majority of them, like there could be variation. But for majority of them, that was how it was. In terms of growth prediction, Andrews radiographs provided the best indication and that maturity had reached the peak velocity stage, while chronological age was good, but cervical vertebrae method was consistently the worst. This is as according to Praveen. Then comes a lot of articles which keep telling us that cervical vertebrae alone cannot be used as a good maturity indicator for mandibular growth assessment. Again, this was in 2016. They said morphometric changes of cervical vertebrae and the cervical vertebrae assessment methods cannot accurately identify the mandibular growth peaks. And even all these studies by, again, Bassety, which told us that the maximum growth which happens in CSP state, and the Ball et al. Study, the Bay to the million, says that, well, cervical vertebrae cannot be a good indicator for growth. Well, it can be used together with other tools. So to conclude, let's say that skeletal maturity indicators, we have clinical methods, radiographic methods, we can have biomarkers. A lot of study with biomarkers. There is this dihydroepiandrosterone, as suggested by the Prem Kumar said, the Tulika madam, has insulin-like growth factor, which is assessed in urine, growth hormones, parathyroid hormones. The biomarkers are also a lot of investigations on even ECS has been used. So a lot of parameters have been used to find out whether the person or the kid is in growth spurt, and this spurt has to be related to mandibular teeth. So exactly these are the set of articles which can help us identify. You can go through these articles and do cross-referencing and come out with a good assessment of growth and say that yes, this is a person who has growth, the growth is nearly completed. That is quite important for Finlaw. Now let's come to the second part of it, the skeletal assessment. And we will start off saying that the basic necessity for a good skeletal assessment is the person has to be in natural position. The lips needs to be relaxed and it has to be assessed in centric relationship. This is as suggested by Arnett and Bergman. That is the base necessity for skeletal. We'll start with a skeletal assessment for transverse. Well, we'll keep it very, very simple. After the transverse assessment, you need to find out whether are you looking at an asymmetrical mandibular growth or a symmetrical mandibular growth. That's it. Well, here, two terms need special references, laterography and lateral occlusion. Possibly record the intermolar and intercanine width. Is there any maxillary constriction or valar ridges also can be considered to find out whether there is a maxillomandibular transverse width or should we be employing any maxillary transverse expansion for assessment, for growth to happen. Well, the best parameter is drawing a midline for the facial midline, which just takes 2 points. I've seen most of it when questions are asked, they take mentone also. No, so just 2 points, glabella and the midpoint between the lip, which is called as the M point or midpoint of filter, and check whether the mentone falls in line. Now, if the mentone doesn't fall in line, now in this particular case, it is shifted to the left side. We'll check for the midlines. If the midlines are also equally shifted. Now, this kind of a shift can be due to two reasons. No, I would say three reasons. One would be a skeletal shift, which could be due to a hemimandibular hypertrophy, hemimandibular elongation, or a hemifacial microsomia or undergrowth of one side, which can definitely be depicted as a midline shift. There is an excellent discussion in Martin Pabon, which helps us identify elongation from hypertrophies, where midlines are not shifted. There is scanting of occlusal plane. One is more horizontal, one is more vertical. Well, that's a good read. But here you find that the midlines are not coinciding. Now we need to here also. There is actually a midlines which is not coinciding centric relationship. Keep it in freeway space and check for the midline again. In freeway space, if the midlines coincide, that means that it is a dental shift or it's a functional shift. It is functionally the mandible is shifting to one side because of the presence of frostbite. or a bilateral construction of maxilla which is shifting mandible to one side. So that concept is called as lateral occlusion. A pure bilateral expansion of maxilla might help us make the mandible grow symmetrically. And if it is equally important is to find out whether it is there any dental reasons for shifting if the canine is legally blocked, that has to be treated orthodontically, which we will come later on. So ultimately, at the end of transverse assessment, we need to come to a conclusion whether it is a skeletal asymmetry, a functional asymmetry, or a dental asymmetry, which is coming up. Now let's talk about the vertical assessment. Vertical assessment clinically can be done. It's very, very simple. Let's make the middle facial height the gold standard. That is from glabella to submaxion. That is non-alterable. That's not cannot be treated with orthodontics. But the lower facial height should be equal to that of the middle facial height. Now, if at all you take a divider and you need to open after you are relating to the middle facial height, then or if you need to open, it's an increase in lower facial height. If you need to close the divider, that means that there is decrease in lower facial height. So it has to be similar. The middle facial height and the lower facial height should be similar. One of the things that can be clinically looked into is when you have a decrease in lower facial height, there is squeezing of these lips. There is mentalis, there is a deep mentolabial sulcus. And when you have an increase in facial height, the chin, there is incompetence, the lip gets stretched. So there will be puckering of the chin, which is noted. So lower facial height, there will be incompetency and stretch of soft tissue. And in decrease in lower facial height, you would find that the lips are getting squeezed between because of the vertical lack of the vertical dimension. Well, now here you have one parameter which is suggested by Reineke in surgical discussion C. When you have an increase in lower facial height or a decrease in lower facial height, both maxilla and mandible falls into the lower half. So when you have a maxilla and mandible in the lower half, you need to find out which jaw is contributing to the increase or decrease. That is done by a third parameter, that is from labella to the lower lip vermilio-cutaneous junction and from lower lip vermilio-cutaneous junction to menton. Now, in case of an increase in lower facial height, this lower part is more. That means that the mandible is contributing to the increase. Now, if it was the upper half which was increased, that shows that the maxillary part is increasing to the lower face. This we call as a third ratio, which can tell us that which jaw is causing the increase or decrease, and likewise treatment can be directed toward that jaw. Then other clinical parameters like FMA, antigonial notch can be employed for so vertical growers who have an antigonial notch, horizontal growers have less of antigonial notching. Bizygomatic bigonial width ratio, mostly when you have an increased bigonial width, there will be masseteric hypertrophy, and they're mostly towards horizontal growers. And vertical growers have relatively weak musculatures, and they have open gonial angles or an obtuse gonial angle, and the horizontal growers who have a kind of acute gonial angle, so 90 degrees. Well, the vertical assessment, we were seeing cephalometric. So these are the clinical parameters. The lower facial height, well, that is an excellent parameter. Then equally with the antigonial notch palpation, the masseter hypertrophy, then the clinical FMA, and we tend to first say that it could be a vertical growth, which can be confirmed cephalometrically by middle facial height to lower facial height ratio. Well, some textbooks say 45 is to 55 in most points. In that case, Nacion is taken as a reference point. If glabella, then it has to be 50 is to 50. And 45 is to 55, then the upper part is Nacion, which is lower than glabella. Well, Sesoni analysis gets there because all of the planes has to converge and meet at the occiput. But if the planes doesn't seem to converge and they are parallel to each other, that more shows more towards a horizontal growth pattern. And if they converge earlier, that is a sign of a vertical growth pattern. Well, facial height index, that is between the lower facial height and posterior facial height. Well, people who have got increased lower posterior facial height are tend more towards horizontal growth, and who have a decreased lower facial heights are basically towards vertical growth. But we know that York has divided vertical growers and horizontal growers, vertical growers into three types and two types and horizontal growers into type 1, type 2, type 3 rotators. Well, I have a reference about Bjork's article about mandibular rotation. Well, again, Bjork has suggested what structural signs to find out whether a person is in vertical grower or a horizontal. That includes the inclination. There are 7 structural signs: inclination of the condylar head, the curvature of the mandibular canal, the shape of the lower border of the mandible, inclination of the mandibular symphysis, interincisal angle, intermolar and interpremolar angles, and a lower anterior facial height. These are 7 structural signs, and these structural signs help us identify whether the person has a downwardly rotating mandible or a forwardly rotating mandible. So this could be the sum total conclusion. So these all parameters together, we come to a conclusion clinically and radiographically that yes, this person is a horizontal grower, which could be better for functional appliances. Now, how do you do an anteroposterior assessment? Well, in most of the textbooks, there is a reference to use a glabella perpendicular and submacion and pogonion should fall in line from glabella perpendicular. Well, let me tell you, this happens mostly for Caucasian or Westerners where the home where the submucion, pogonion, and glabella is in line. For most of the Dravidians or South Indians, we have a tendency to have a lower half which is slightly in front. So most of the people end up having a convex profile, but that is not exactly convex. Now look at this line here. We have a glabella perpendicular drawn. Submucion, the patient looks to have been in a class 1, but slightly the submucion is in front. Now, again here, this is a class 2 patient. We have diagnosed the patient as a class 2, but when a glabella perpendicular falls in line with the pogonion, and we have a submucion which is in front, which might make us conclude that there is a maxillary excess. Well, hold on. Here we have a case, again, a class 2, where a glabella perpendicular is drawn, the submucion falls in front, and when we do a VTO and bring the mandible forward and bring it in relationship with submucion, it looks like a class 1, it looks better. So submucion perpendicular should be a better parameter than glabella perpendicular. Submucion, if at all, when a submucion perpendicular is stopped and pogonion doesn't reach up to that particular level, or it is less than nearly 6 to 8 millimeters, well, that is surely a class 2 malocclusion that needs advancement. Well, anteroposterior assessment clinically, this is for theoretical knowledge, there is 0-degree meridian. Or most of the examiners asking about what is a 0-degree meridian, and a plastic surgeon, Mario Ulloa, who suggested the 0-degree meridian. It is a perpendicular which is drawn through the Frankfurt, and all 3 glabella, submucion, and pogonion has to fall in line. Well, there is this method called a 2-finger technique, which was called as Kettle's method. It was introduced by a British orthodontist, which is also called as Foster's method. Well, this is placing 2 fingers over the upper lip and the lower lip, or you can place it inside. You're removing the lip, you can place it directly onto the mucosa over the upper. And looking at how does the upper, how do the fingers relate? If it is a class 2, you might have to have a upwardly directed one because mandible is small. The fingers get upwardly directed. If it's a class 3, the mandible comes in front, has to be downwardly directed. Sometimes some people say bending, you will have to bend one. In case of a class 2, you'll have to bend the upper finger. And if in case of a class 3, you might have to bend the lower finger. Well, that is also, but this is a 2-finger technique which could be employed, but it has to be employed with a lot of caution. And rightly, you can place it directly onto the mucosa, removing the effect of lip. Lip step, as suggested by Korkos as a person, can be used for assessment of lip step. The right or a right relationship with a mildly negative or a mildly positive lip step, or marked negativity or a marked positivity might suggest that class 2 or class 3. So the lip step can be used. Clinical VTO, well, clinical VTO is bringing the mandible in front and checking whether the place that it. Well, this was suggested by Kriegmore, according to Caesar Kriegmore's textbook. They have said Kriegmore is a person who spoke about VTO, but a lot of articles say that it is Frankel who used to bring as the mandible look for the clinical VTO. Well, again, there is a small discussion about full VTO, half VTO, if it is a mandible is brought into an edge-to-edge relationship, and you find that the VTO is positive, that means that it is a whole is contributed by the mandible, and if it is half VTO and the profile improves, it is half by the mandible and rest is contributed by the maxilla. So you need to employ some means to retract that. So the term VTO was coined by Holdaway, that Holdaways, and it's a cephalometric VTO, which is a different discussion. Chin throat length, again, clinically can be used as an excellent parameter. Most of the class 2s, deficient class 2s, will have a very small chin throat length, which may not be appreciable, and bringing the mandible in front can give them a good throat length. So how do you do a anteroposterior cephalometric analysis? That was about clinical. So clinically, we said a lip step, chin throat length, clinically VTO bringing the mandible in front, a subnation perpendicular. Altogether, we'll say that yes, here the mandible looks deficient. So cyclometrically, there is this excellent article which came up by Show Madam, who compiled all of these 21. Uh, and this is one of the favorite topics for examiner, asking about A and B, who gave the A and B riddle in 1948. Well, what is AXD? What is AXD? What is which appraisal? Why do you call it which appraisal? Who gave the which appraisal? Mm, Uh, and what kind of so what are the ill effects of which appraisal? Well, this is an area where so this article you can get us and all these parameters to say has its own advantages and disadvantages. So with advantages and disadvantages, it is very important that we actually do a critical analysis. In some cases, we could use it for use, and in some cases, the same parameter may not be. Let's say angle A and B is the most used for anthroposis calculations. But the biggest issue is when you have a vertical grower, when the mandible is growing downwards, A and B is not exactly a which appraisal. It is one of the very good parameters which can tell you about anthroposis. But when you have a functional occlusal plane, which is very difficult, or dentition, which is causing an alteration in the functional occlusal plane, which appraisal cannot be employed. So each of it has their own. So ultimately, I would say that basically there are four analyses. One is angular, we call it linear, and projected linear. Linear analysis has this issue of magnification. You taking a cephalogram and reading a linear measurement, well, if there is a magnification, the value might change. Pre and post values might change. So some of the linear would be condylene to point A, the maxillomandible differential as suggested by McNamara. Well, angular are less liable for magnifications. So, but the surface points, like we know how difficult it is to locate a point, a B point, and so A point, A and B would be a parameter which is quite difficult to locate in a cephalogram. So now there's a lot of analysis which uses centroid points, that is point in space. So which is less liable for surface, I mean, surface changes or changes that is caused by the position of the teeth. And projected linears are you have a plane, let's say occlusal plane, palatal plane, transverse horizontal plane. A point and B points are projected onto that plane, and a linear measurement is measured there. So these are the of these 21, majority falls into angular, which is a surface points or centroid point, linear or a projected linear or a bisected one with an angular. That is also the beta angular is one of the kind, but bisectors are used. So that gives us a better identification of class 2. Next, any discussion with class 2 has to be done considering the position of the mandibular condyle. We need to know whether the mandible is small or mandible is big, but it is positioned posteriorly. So how do we find out? Now, this concept is called as retrognathism and retropositioning. To find out retropositioning, we use a parameter called saddle angle. Saddle angle is a diagnostic angle which, if it is increased, shows that the mandible has to travel from the very posterior side. So even if mandible is of adequate size, because it has coming, is placed posteriorly, and these kind of appliances, I mean, these kind of configurations are not good for functional appliances. So Saddle angle is considered to be a diagnostic. And when you have a prognostic, that is the articular angle which is compensated or non-compensated. The articular is compensated, that is a decrease in articular angle has happened, or the ramal height has actually compensated enough for that, then it is called as a better prognostic indicator for functionals. And if it is not, if it is downwardly grown, well, it is considered to be not a good indicator. So there are a few articles which says that, well, this article which suggested that class 2 and class 3 is less support for saddle angle, and some, it was very early established according to this. From Germany, they say that it is saddle angle is established very, very earlier. Well, with regard to the length of mandibular base, we have a discussion of mandibular base is NSE plus 3 millimeters. That is supposed to be the normal for a particular age. So if the base is short, we can call it retrognatism, and well, that is very, very good for functional appliance. But if the base is as good or it is as much as the length to the cranial base, then there could be two reasons why the mandible looks smaller. This one is due to the forced protrusion. Well, any kind of forced protrusion or occlusal interlocking or occlusal lock corrections can help us correct that class 2. But if mandible is morphogenetically built into a skeleton in a posterior position, the temporal fossa is posterior, functional therapies are very bad. So you need imperatively find out whether it's retrognathic or retroposition. Well, in class 2, well, there are two more good discussions about Stutzman angle, which tells you that it is functioning, when a functional appliance is given, it is working well. There is most posterior growth direction, and there is the trabecular pattern which changes along with the functional appliance, which make us feel that yes, it is responding well to functional appliance. Equally, a perpendicular which has gone from SE or cella to SE plane, a perpendicular which has gone from SE to mesial, and dividing the gonial angle into upper gonial angle, and the smaller posterior can again tell us that whether there is a good positive growth direction in the condyle happening. Well, Moyers in 1980 gave us this excellent article saying that class 2s are very enigmatic. It is one of the most difficult malocclusions to understand. There are 6 horizontal types. There are pseudo class 2. There are 5 less clearly differentiated vertical types. So class 2s, for a person to understand class 2, we might have to look into in detail, and it is quite enigmatic. So that was about the assessment for skeleton. We did anthropost assessment tells us whether it's class 2. If it's class 2, it's retroposition or retrographic, vertical grow or horizontal grow by vertical assessment, and symmetrical or asymmetrical by. Let's come to the next assessment, soft tissue. For a class 2 assessment, per se, soft tissue assessment, we have a lot of cyclometrics like S line, B line. We have gnathic profile field, a photometric, a photographic analysis, which is suggested by Schwarz, which is a favorite question by examiners. Gnathic profile field. What is gnathic profile field, and where do you do the analysis? Well, in terms of a clinical assessment, soft tissue, perioral muscles and chin are two structures which has to be evaluated in a big way. So lip forces on lower incisors definitely will pull the lower incisors back. It will retrocline the lower incisors and it will exaggerate the class 2. It is in fact a vicious cycle. There is proclined upper incisors, there is lip trap, there is more retroclination of the lower incisors, mandible gets to log behind the maxilla, and there is worsening of the skeletal pattern. That's exactly what we said, that class 2 worsens with growth. So because if you have a lip trap, the mandible is locked and it cannot grow because of the soft tissue interferences. Well, this article talks about how the soft tissue behaves in a class 2. Well, there is increase in upper lip length and lower lip length. Well, the upper lip length, there is upper lip thickness as it decreases with growth. That's exactly what he said. But again, this is one important thing in class 2. Many times, we tend to diagnose a class 2, but it will be a class 1 base with chin deficiency. So many of the chin deficiencies are diagnosed as class 2. Now, how do we come to a conclusion that this is a chin deficiency? Check for the dentition. The dentition is in class 1, and if it is in a class 1 lot and canines are in class 1, most of this could be due to a deficient chin. Well, in this particular case, we might conclude that this is a mandibular deficiency. Well, if you look at the molar relationship, it is class 1. So in that particular cases, the best thing is to add a chin after the orthodontic therapy is done, rather than bringing the mandible anteriorly, which may not be the exact. So chin deficiency might many a times confuse a class 2. Now, one of the best indicators for chin assessment is actually a perpendicular from the lower lip. So when a perpendicular is dropped from the lower lip, if pogonion falls in line, well, that is adequate chin. But mostly, if you draw a perpendicular and pogonion doesn't come there, then that means that chin is inadequate. Or else clinically, we can actually check for chin by pushing and looking at whether chin is adequate. Here, this article tells you that a class 2 to class 1 correction will not augment chin. Chin has to be treated separately, and separate treatment or augmentation of chin needs to be done. It is a total different entity which doesn't have anything to do with class 1, class 2, or class 3. So that is about the soft tissue assessment where we talked about the lip and chins. We're coming to the dental assessment. Well, for class 2s, we need to check for in-standing lateral incisor or a class 2 division tooth where there is this concept of forced protrusion. A constricted maxillary arch where the mandible is being prevented by the foot and suprancipital, and a small idea about lower anterior spacing. Well, these kind of cases, if you look at that, you find that the lower upper incisors are retroclined and is preventing the mandible from growing forward. And this concept is called as the forced protrusion concept. A constriction of the maxilla. Here you have the exact foot and suprancipital, which will prevent the mandible from growing forward. So expansion of the maxillary arch alone can help us correct this. Now, there is a reference by Praveen saying that in class 2, if you find lower incisor spacing, unless it is of a lesser tooth size, I would say adequate tooth size with lower anterior spacing, if you see that, that means that the mandible is genetically good, but it is placed. So that is a kind of a poor responders to functional appliance. Well, this was one reference which I found that spacings, if you get to see in lower anterior in a class 2, which is basically deficient, and that shows that they might be poor responders to growth. Well, dental midlines also needs to be recorded because, as said, if it is a dental reason for midline shift, it should be corrected orthodontically, not by functional therapy. The last word in dental is about dental class 2. See, many a times when the canines are labelled locked, the molars might come in front, which can be found out clinically by palpating the tear edge. The tear edge falls or relates to the distobuccal cusp. That means that the molar has migrated initially. So a distalization of the upper arch and eruption of the canine is better rather than the functional appliance. So here we have a discussion about understanding how do you understand a dental class 2 from a selfie class 2. Dental class 2 usually have a mesial migration of molars in the maxilla, which is actually clinically found out by Curie's procedure. Dental cephalometrics, well, there is this Bellard conversion tracing which uses long axis of the upper and lower teeth. The long axis of the upper and lower teeth is related well to the basic bone using the maxillomandibular angle, the IMPA, and we can find out whether it's a class 2 base or a class 1 base, and we can ideally find out the incisor position. Well, the most important thing with cephalometrics for lower is lower incisor positioning. Most of the cases, as said in class 2, will have compensatory lower incisor profination, and most of these functional appliances will further profine the lower incisor. So adequately possible changes needs to be made. So in this particular case, we see that there is lower incisor profilation. A twin block was placed and it exaggerately increases the lower incisor, which would be least stable now for treatment of for extraction on orthodontic needs to be employed. You cannot leave a profined incisor, which is one of the least stable ones. So whenever functional appliances are given, give a thought on lower incisor. If it is profined, make sure that steps are taken to prevent further lower incisor profination. Let's talk about functional assessment. Well, airway, tongue, pathoclosia, TMV, and speech. We'll to airway. We'll do a preliminary analysis of airway because that impacts the future of a person in a big way. any advancement therapies, be it surgical or functionals, the airways are tend to improve. But if a camouflage is passed by extraction of forecoat, the further improvement in airway is just impossible. Most of us towards the 40s and 50s put on weight, and the airway further gets compromised because of the obesity or the narrowing of the posterior space. So enhancement processes in mandible, like any form of functional. So airway assessment is quite important. Look at the mouth breathing tendency, look at the ALA, whether it is functioning properly. A McNamara's analysis of upper airway and lower airway needs to be recorded. If you have a narrow airway space, well, that may not be a conducive case for orthodontic therapy. Well, most of these articles say that vertical growers or hyperdivergence definitively has a narrow airway. And the mouth breathers mostly are downward growers. They have increase in lower facial height and they have a compromised airway. So this is what airway analysis tells you. And the heavy chances of developing obstructive sleep apnea for hyperdivergent malocclusion. So advancements with regard to functionals or surgery should be considered. Well, this is a case where the CBCT shows that enhancement, the functional enhancement, the amount of airway increase that has happened because of the advancement. Well, functional appliances are supposed to be good changes in, can bring good changes in the airway. Now, path of closure, this is a discussion which is there in Thomas Rakosi. That we need to find out whether the mandible has a forward path of closure or a backward path of closure. See, class 2s may not be the actual class 2s which we get to see in clinics. Sometimes we are asked to give occlusal disinfectant splints for 6 months so that there is breakage of muscle memory and mandible is taken back to the true skeletal centric relationship. So what we see clinically as a class 2 might be much lesser class 2. Actually, this would be much severe. So a path of closure assessment is very, very important. So the first contact, does the mandible go anteriorly? Does the mandible gets locked inside or it doesn't have any shift? So from the first contact, if it's moving anteriorly, there's a forward shift or anterior slide, which is like a functional appliance, but if it is class 2, functional appliance may not be working in such situations. If you have a backward path of closure from initial contact, that means that there is a concept of forced reclusion. Yes, functional appliance can help. No shift, fine. We can decide accordingly. The tongue assessment, you need to check for whether there is a large tongue or a small tongue. The large tongue is a tendency for the mandible to lower and a downward growth of happen. These are assessment methodologies like direct fluorography, indirect palatography, then a cephalometric assessment tool, which is discussed in detail in Thomas Rakosi, and the position of the tongue, what does it cause to the anteroposterior? Well, there is a downward growth happening. Well, equally an aesthetic assessment, which doesn't fall exactly into a functional one, but an aesthetic assessment like micro-aesthetic lip line, but this is a bit more discussion, which I think is beyond. It takes a lot of time. So then for class 2s, a compliance assessment is a must. We need to know what are the self-motivating things, what are the social influences. They say that there are enablers, there are barriers, and both enablers and barriers. So must be prescribed airtime. Peer influence are both enablers and barriers. Well, no motivation, lack of physical and psychological impairment, forgetfulness are definitely barriers. So these are the things which during questionnaire, if you can talk to them under these perspectives, you could better identify whether are you looking at a good class 2 or a compliant class 2 or a non-compliant class 2. So that was a detailed discussion about clinical evaluation. We wanted to find out whether there's a class 2, well, it's a vertical or a horizontal grower. Is there incisors? How are the behavior of the incisors? How is the airway? How is the tongue? What is the compliance of the particular person? How is the soft tissue behavior? So we get an concrete picture about the overall case, and now we have a concrete diagnostic, picture in our mind. And so this is a total picture. That is, with all this, we can decide on to which appliance should be beginning or should we be considering some other treatment options here. So what does the evidence talk about functional appliances? Well, there is a lot of evidences which say that functional appliance does work if it is given during the maximum height velocity. There is this good discussion and profit which talks about temporal acceleration and absolute acceleration. That sometimes there is no absolute acceleration which is given by functional appliances. It is just a temporary increase of growth, and later on that it catches up. Well, most of these studies said a class 2 is a class 2 later on also, and it gets worse and worse. So, with regard to most of the studies which came up later on by Pamela to Locke, Mills and Hill's study, they all say that rightly, the myofunctional appliances are given, it causes great increment in growth. That is, twin block appliances definitively are appliances that does work. And even efficiency study by recently in 2023 done by CV Madam Dr. Vignesh, when they say that functional appliances are efficient and herbs is the most efficient among us. Even twin blocks also have a high degree of efficiency. The changes in the TMJ condyle definitively we can elicit changes. We do see changes with twin block. The dentoalveolar changes in untreated class 2s, which came up a study in 2000, said disarticulation of occlusion to minimize the effect of the adaptive mechanism and taking advantage of normal. You need to unlock the occlusion for the mandible to grow normally. Otherwise, class 2 corrections may not be possible. Well, again, twin block, it does seem to show a lot of changes with time. That is, TV shows greater changes. And well, finite element analysis, which came on 2023, shows that twin block appliances just additional. They give you a lot of condylar changes, and it is a good appliance to change. But a wave in between 2002 to 2015, there was a lot of studies which went against functional appliances, and they said they are just temporary stimulators. 4 randomized controlled trials by Kevin O'Brien, Gafaris, University of North Carolina, they ended up saying that twin block appliances may not give us change. It is just a pure dentoalveolar. Well, as said, 4 randomized controlled trials where this is just a temporary increase in size. Well, later on, a person who doesn't get a functional appliance equally gets to catch up. Well, this was again a multi-centric studies, and ultimately, here we conclude that our results agree in those with the previous study. It appears that early orthodontic treatment for class 2 malocclusion does not confer an advantage apart from a transient in self-testing. But the waves are still changing in 2023, 24, 25. Functional appliances does work, and this is a, uh, chapter in Clark textbook. He is using to explain that see, it is a twin block, gives us 3-dimensional changes. It is a volumetric change you get, and cephalogram, which is a 2-dimensional parametrical assessment, cannot be used to assess a 3-dimensional. So change the parameters for assessment of twin block. The Earth is round, it is not flat. So using cephalometrics for assessment of for a appliance like twin block may not be a good. That he explains with a flat Earth concept. This is a good read in his textbook. Well, we want to find out the amount of contribution by dental and the skeletal. See, we give a twin block. We want to find out how much of dental changes have happened, how much of skeletal changes have happened. Pitchfork analysis is employed. It is actually a superimposition analysis. It's a cephalometric analysis. It's a bit difficult to employ, but pitchfork analysis can be so how to differentiate between skeletal and dental changes. Pitchfork analysis. So ideal case of a class 2 would be an angled class 2 division 1 with a mandibular retrognathism, with a soft tissue trap, severe circumoral convexity, with horizontal growth pattern. And a case which would be not good for a functional appliance would be vertical growth, a dolichofacial pattern of growth, biomaxillary protrusion, or chin deficiency, wrongly diagnosed as class 2, limited growth vector. Peter Bushang actually categorizes patient based on the growth response and growth vectors, whether they are poor responders, good responders. The patients with severe tongue thrusting, these are supposed to be not good indicators for functional appliances. Well, weak musculature, compromised airway, signs of poor growers, functional appliance needs to be crossed out. We have a small discussion on understanding the basic. It's a very small discussion. Well, this is our condyle, and this is a joint, which is we get to see the articular eminence. We get to see the disc in between. There is this condylar, the glenoid fossa, and you see that we might say that a functional appliance might uh, yes, a functional appliance might keep the glenoid fossa in a relationship something of this kind. And there is this condylar stretch which happens on the posterior side. There are a lot of philosophies, I think, that is beyond our perspective. Well, there has to be, how does the myofascial appliance work? One is the stretch of the non-muscular tissues on the posterior side. There will be venous engorgement, there is vascularity, there will be inflammation, and there is this retrodiscal pad activity, and it finds, well, mandibular condylar cartilage is a very different cartilage because of the presence of free skelettoblasts, free chondroblasts and skelettoblasts. They are susceptible to a lot of environmental changes. That layer alone makes a lot of difference. And condylar cartilage are susceptible for environmental influences, and myofascial appliance could work. So, in a likely scenario, a functional appliance brings a changes of nearly 6 to 7 millimeters. So how do you get the 6 to 7 millimeter? It is not purely by condylar growth. So there is equal contribution in terms of 1 to 2 millimeters from each of it. Like condylar growth, there will be 1 to 3 millimeters. There will be fossa displacement, growth, and adaptation. Functional recruitment treatments can give us nearly 0.5 to 1.5. There will be more favorable growth direction, withholding the maxillary growth, differential upward growth of the mandibular teeth, and healthier effect. So this was taken from Functional Appliance by Thomas Graeber, a version of Graeber's textbook, which actually spoke about in detail the castration and ear correction. So a functional appliance, nearly 6 to 7, this is the likely scenario. Now, a discussion about appliance selection. Now we have concluded that functional appliances are appliances in an orthodontic toolbox. They can be employed if you choose a right case. We can get an enhancement of mandibular growth. We've been doing in BBC Calicut for nearly past 20, nearly 40 years. The pin blocks are the mainstay treatments, and it says we see that we have recalled a lot of cases. Well, many things. Most of the cases are stable, but we do see few cases which do relapse, do get back. Those cases are mostly watery growers or poor growth responders. We get to the good response, but so ideal cases, if you choose an ideal case, it should be a good tool a good tool in our orthodontic box. So how do you select an appliance? Well, let's say we have removable appliance and fixed appliances. Removable appliance, we have twin blocks and Frankel's functional regulator. I would suggest these two as good removable functional appliances which have withstood the test of time, and they are here to stay. Well, fixed appliances, we need to consider fixed functional appliance when we have dental situations where mandatory needs are free functional. Well, removable functional appliance can be tooth bond, tissue bond. Well, we know the tooth bond, the best tooth bond is spin bond. It is absolutely tooth bond, so we need to have teeth. It is suggested in early permanent dentition. And a tissue bond like Frankel, which the area of working is vestibular area or operation. Well, this space, it's a early permanent dentition with all teeth, and the patient is in class 2. The molars are in class 2, the canines are in class 2, a twin block was placed, as expected, there is a good growth, there is a good correction of profile, and the class 2 was corrected into class 1. And many of them may not need a second phase of fixed appliance therapy if at all we could manage with a good occlusion. But sometimes if you have a midline shift or final occlusive correction can be done with fixed appliances. So whenever we have early permanent dentition with good growth vector, twin blocks are the best. So we do have a discussion about twin blocks later on today. Well, but some cases do come to us. This boy came to us when he was nearly 10 to 11 years. He was extremely bullied because of a severe incisor proclamation, and he had a severe lip trap. His lower lip was getting trapped, and lower incisors were severely getting retroclined. So we looked at the dentition. Well, in this particular, giving a thin block was impossible because we are in retained deciduous. The upper block, there was mostly it was deciduous teeth. So we decided to give a Frankel supplements and Frankel because the patient was very compliant. This is the post-Frankel result. It doesn't cause any hampering for eruption of teeth. That's what I said. The area of walking is actually vestibule. And the skeletal correction which you get with functional appliance is definitely better than that we get at Makinla. Now we into a final fixed appliance phase where it's tracking. We given the lower lip bumpers for the lower incisors to proclaim because of the effect at the time. Well, this is another case. Again, we cannot give a twin lock, but the patient has severe class 2, severely psychologically hurt. We do have very few teeth. Then this is exactly Frankel is called as a chickmunk species. This is a major reason why people don't wear Frankel, but it's an oral gymnastic plan. It helps a lot of muscle exercises to happen along with it, and a class 2 correction happens. Well, this is supposed correction. This came up excellently. No, a fixed functional appliance is considered when we have a crowding. We cannot procline or bring the mandible anteriorly because of the upper anterior. Now here in this particular case, there was upper anterior crowding. The lowers were relatively well aligned. So we did a upper and lower strap up or a bonding together. And we went in for the heavy wire, 21, 25 wires with additional torque in the lower anteriors and a power scope was given. No, but it's because these kind of appliances definitely will have higher propagation of the lower incisor and molar dislocation effects are more. So heavy wires and stabilization of the lower anteriors needs to be done prior we get into the space. Well, this was the post-treatment results. It came out excellently because adequate care was taken for the lower incisors and fixed functional appliance was planned. Well, in this particular case, again, the mandible cannot be brought anteriorly because of the post-proofing concept. The upper incisors were aligned, the lower incisors and the lower anteriors was taking time, so we employed the advancing appliances that uses molar area. Now, with advancing or when you use molar, the class 2 functional forces is in a range of 350 to 400 grams. That is, molars are facing a load of nearly 350. So many times molars might rotate, molars might get intrude, molars might be very mobile. So it is very, very important that we stabilize molars with chromosome arch or TPS of heavy gauge wires. Even lower molars needs to be stabilized with lingual arches prior to you employ an advancing because it gives a lot of force onto molars. It's very heavy. So this also is a case where we did a advancing. So to conclude, let me tell you that Frankels and twin block Frankel appliances can be considered when you have a lack of teeth quite early, there is soft tissue trapping, when there is lip trap, lower anterior crowdings in early phase as well. Frankel is better and early permanent dentition. With an advancement when it is possible, definitively twin block is the best compliant appliance. And if you have a dental issue or pre-functional needs to be employed, you can use a hybrid or a rigid fixed functional appliance. Rigid fixed functional appliance shows more skeletal changes, and the hybrid fixed functional appliance or flexible it shows more dental changes. So let's come to the final discussion with bite registration. Well, why do we do a bite registration? Why do we register a wax? Because class 2s are occlusal logs. They hold the man behind and they cause a more posterior growth direction, which is very unfavorable. Uh, and a bite direction or a bite registration gives a more favorable growth direction for the mandible, and we get an enhanced growth. expecting enhanced growth of mandible. Still, for bite registration, I would suggest a must read is Removal of Orthodontic Appliance, Chapter 7 in Braeburn Unit. You need to read the chapter before you get into exams for bite registration. It's a excellent read up. And well, an article, How to Take a Vacuum in the Journal of Orthodontic. And definitely, if it is twin block, Clark's bite registration has to. I'll help you in that. Well, there are few advancement philosophies. Newman suggested that do maximum advancement, but let it be comfortable for the patient. That is what exactly Newman was telling. Well, Frankel was saying that don't give too much of advancement. Keep it to stepwise advancement of 3 millimeters, and every 5 to 6 months give a small increment that is more physiological, and the patient compliance is better, and the contact adaptation is much better, as according to Frankel. Well, Woodside was saying that you find out the maximum protrusion and keep it 3 lesser than that. That is according to Woodside, and that is what Anderson used for his activator. That was the Woodside philosophy. This is all for advancement. For vertical, well, again, there is a Harvard, there is Woodside, there is North American philosophy. Well, here in North American, they are asking us to encroach 4 beyond the freeway space in terms of vertical. But well, Schwarz, for his forerunner of Winlock, which we call as the split plate, where the amount of advancement was 50%. The maximum proportion, you have to take it to the 50% from the maximum proportion. Well, Roccabado's philosophy is what Class is advocating, that 70% of the maximum proportion part could be of a good investment. That is what Clark says. Well, as a general principle for bike registration, keep rule of 10. May not be rule of 10, but when you have a more anthroposid advancement, that particle will be less. More than 10 millimeters, always to stepwise advancement. If the forejet is more than 10 millimeters, let's advance stepwise. So one step must be 7 millimeters, and second step would be 7 millimeters. Don't take it more than 10 millimeters. Vertical growers definitely grow beyond the freeway. Even in horizontal growers, you need to encroach into the freeway space by 2 to 3 millimeters. That gives you stability of a plant. But if it's vertical growers, definitively you can increase, but ultimately causes the molars to improve. And for horizontal growers, you can give a more anterior advancement, that is fine, and keep the incisal clearance very low. Now, most of the times when it comes for examinations, when an appliance on the day of appliance delivery, the interincisal clearance seems to be towards the higher side, and later on a contrasting habit might develop. So make sure that the interincisal clearance is kept towards a minimum. So bite registration philosophy. There are two kinds of bite registration. There's the horizontal growers and vertical growers. Check for the molars. Draw a line from the mesiobuccal cusp down. Canines can be used, as in caliper we use canines as a good reference point. Take canine into class 1 and incisors bring it to the H2 edge incisor. And well, this is how you make a bite block and look at the amount of advancement. So now here you look at this one, find that the amount of vertical opening can be found out with two markings on the area of molars. So the amount of vertical opening in molars, and this is what Clark calls as comfort zone between the interincisal area of upper and lower. This can tell you about the amount of incisal opening which has happened in the anterior. Now, well, you can record the amount when in occlusion and when after advancement, how much it has happened. This is how it is. You draw a line from the mesiobuccal cusp. Then you can measure the vertical. You can measure the vertical in the incisal area. You can measure the vertical in the posterior area, and you can record it. You can write it on top of the. After advancement, we look at the amount of anthroposid advancement which you got. It needs to be recorded that was a 6 and vertical clearance is 4 Eschler has used a term called pathological bite registration when the lateral incisors are lingually placed. Any kind of bite registrations might cause a cross bite, so a pre-functional needs to be employed. So Eschler was a term, coined the term pathological bite registration, and it demands the use of a pre-functional phase. Vertical assessment we need to do in vertical dimension in previous space as well as the patient when is in occlusion. In previous space or rest position, the 2 points which is marked here is calibrated. And then when the patient is in centric relationship also, the measurement is taken and the difference is actually different. Well, this is one technique. You can find out the amount of power speed which is there. You relate and keep it onto the underneath of the upper model, you can find out the amount of power speed. And if the upper model is kept onto the lower base, you can find out the cuspal, is there any cuspal hang, a palpal cusp hang, and you can decide whether what kind of expansion it demands. Well, functionals, again, the next asset is midline matching. Well, that is quite important to decide whether should I match the midlines or should I leave the midlines. If it is a dental midline shift or dental reason for midline shift, you should leave it. You should not match the midlines because that might cause an asymmetrical mandibular growth. But if you find that there is a scheduled reason or a functional reason, well, midlines should coincide, or you can definitely try to match the midline. That is a midline is very, very important because of the reason that you might develop asymmetry later on. Well, this is a technique was suggested by Varun Kalra sir. He asked for a better relationship for a patient, just mark with a marker so that the patient can actually bring it and understand the relationship better than using the midlines, which is very difficult for the patient. So a marking is definitively uh, mm, uh, a thing which can help the patient bring the mandible anteriorly and in the same line. With regard to the techniques which is used, we use wax, a modeling wax which is softened with warm water. It is curved, just placed onto the mandibular arch, and it is better we don't place over the incisors because if you place it over the incisor edges, they might create flash. Midline matching is very difficult, and the aesthetic assessment is also very difficult. So let's keep it beyond the incisors. Don't exceed beyond the second molars because lateromediscal pad, no, the lateromolar areas, it could cause pain and the mandible might shift. So it is better you don't encroach into areas beyond the second molars. Keep it within the limit. The patient has to be seated in natural position. A mirror needs to be given as Kalras suggested, draw lines in the teeth so that they can efficiently bring the middle anteriorly to match the midline. Then I happened to see this good video with Panchali who was demonstrating. So before exams, read through this or looking into this one can help you do a better bite registration and make all the necessary changes or one. No, you can register it. You need to write it down. You can use the top of the card to register, and it has to be symmetrical. The left and right side, vertical is 5 millimeters on the left side. It has to be equally 5 millimeters on the right. The anteroposterior also needs to be similar if it is a, class 2 division 1. But if it is subdivision with a symmetry, well, the corresponding alterations can be made. Now, why don't you do wide registrations on a task? Now, why do you have to do it on patient? Many other orthodontists might think of doing it on a task. There was this interesting thing which we found that don't do it because a plans does not fit. There is asymmetrical biting of a plans. The patient may not be really comfortable. This was taken from Weber and Newman because they were saying that this habit of doing it in articulated model may not give us the results which we want. To end, we'll have a final discussion on wide registration gauges. Well, uh, George Bite is what Lark suggests to find out the maximum proportion part. There is a lot of markings which can bring the mandible to the most protrusive position and we can record it. For bite registration, Project and Exacto Bite. Project is used in Europe and Exacto Bite in USA. There are color codings like for class 2 division points of blue with intersocial clearance of nearly interinsides of 2 mm and yellow which has got more interincisal clearance can be employed in case of vertical growth or in case of class cases. So there is color coding of blue, there is a color coding of yellow, and this George Bite can be employed to find out the maximum proportion part. Well, this is how a bite registration at the end should look for a vertical grower and for a horizontal grower, where we have taken up the maximum, the amount of advancement was canines in class 1, molars in class 1, incisors in H2 with minimal incisal clearance of 2 mm. And where you get, if it is 2 mm in the premolar area, you get to nearly 4 to 5 mm. That's what we get. So bite registration, well, is a technique which can bring the mandible anteriorly and give a reference for mandible to be placed anteriorly. So to conclude, let me say that our duties, this was written by Angle, and it is actually reported in large textbook. And it's an excellent say that our duty as orthodontists force among us great responsibilities. There is nothing which a student of orthodontic should be more keen than interest in art generally, and especially in relation to the human face. So this is basically art, and our life should be devoted to understanding human faces, because for each of his efforts, whether he realizes it or not, makes for beauty or ugliness, for harmony or inharmony, for perfection or deformity of the face. Hence, it should be one of his life studies. So, our maximum effort should be to analyze, look into human faces, try analyzing them, and come out with better situations, a better analysis, and better appliances to treat. Well, thank you very much for your patient hearing, and I sincerely thank my department, my staff members, my postgraduates who were very helpful in making this. And thank you for your patient hearing. Thank you, IOS and study group, for giving me this opportunity to share my valuable, share my thoughts with you. Thank you very much.